Good afternoon, ladies and gentlemen, and welcome to this webinar, which is today dedicated to the best practice in the treatment of complex aortic disease. It's a great pleasure to have you here and to have as a co-moderator Professor Gargiulo from the University of Bologna. Good afternoon, Mauro.
Good afternoon, Giovanni. It's a pleasure to stay today with you, and it's a pleasure to have the possibility this afternoon to share the experience about the use of stent graft in the complex aortic disease. Then it's good afternoon even to all people that are connected with us this afternoon.
This webinar is supported and gently sponsored by GOR in cooperation with OneView and with Vascupedia. We would like to involve you for this event, and if you like to make questions, please feel free to do it using the box which you probably see on the screen. So please ask questions, and it would be a pleasure and an honor to discuss it during the webinar. As I mentioned, we would like to discuss about the best practice in the treatment of complex aortic disease, sharing the actual knowledge on bridging stent grafts. We have a newcomer during the last months and the 2 years, and we would like to better understand the strategy. So Professor Gargiulo will show later on a case treated with the fenestrated grafts and with the bridging stent, with the new bridging stents, the VBX, the balloon expandable Viabans. And we would like to discuss with you, but before we do it, I would like to introduce the stent. We have done some benchtop tests and looking for optimal solutions. I think this stent has particular features which can be very interesting also in application in treatment of complex aortic disease. The introduction of fenestrated and branch graft has completely changed our attitude to treat these patients. These patients are very frequently have more comorbidities, and they are sick, and they have very often COPD or cardiac problems. So we are happy to use less invasive methods based on the technology like fenestrated grafts and branch grafts. However, this type of procedure is not free from complications. And during the last 20 years, we observed some failure modes. We observed some disconnections of the bridging stents from the stent graft. We saw also crushing of the stent grafts or fractures due to migration of the main body. So we looked for an ideal stent especially for this indication, and the VBX was introduced for the treatment of peripheral occlusive disease, especially at the level of the iliacs. But the feature of this stent are very interesting also for the application in fever and in beaver. And we would like to discuss later on these features with Professor Gargiulo during the next minutes. But before we tested the graft in the patient, we made also some benchtop tests. And as you can see in this slide, Cook gave us a polyester sheath with fenestrations, which are reinforced like the fenestrations we use in the patient. The fenestration were 6 and 8 millimeter in diameter. And first of all, we want to know what happens with the PTFE, what happens with the metallic structure of the stent after flaring. And after flaring, the digital radiography you can see on the screen showed no fracture, no modification of the structure of the stent. The next step was to better understand what is the permeability, the water permeability of the stent after we have flared the stent. And for this, we used a standardized approach, so-called ISO 7198, as you can read here. And we connected the stent with a pump, and we increased the pressure in the pump up to 140 to 80, or even up to 300 millimeter of mercury. And you cannot see any water coming out. But as we did the test with the other tests, with other competitors, you see the leakage from through the PTFE coverage of the stent. So the VBX was a really good stent from this point of view. The next step was to simulate the situation in the patient. So we provoked a sort of migration of the sheet of the graft, or we pulled the stent outside the sheet, and we measured the forces which were needed for the perpendicular and for the axial dislocation of the stent. You see here the BVX, we pulled and pulled and pulled, and the stent offered a very good um, force against this motion. We measured the pull-out forces here of 6 millimeter VBX in 5 examples, and you see here the average maximum of pull-out force was very, very high. So high resistance to this stress. The next step was to perform a fatigue test. As you can see here, we tested also not only the VBX, but also the other stents which are very frequently used for this indication. And the results were very impressive. As you can see in the next slide. Thank you, Giacomo, for this. In some competitors, we saw holes which were caused by the reinforced ring stent, and these holes, of course, in the humans can make endoleaks. You can see here in this short video how it can happen in such cases. After 10 million cycles, we haven't seen any modification of the structure of the VBX. So we are happy about this, not only by macroscopy, but also using the digital radiography. After 10 million cycles, we haven't seen any modification of the structure. Of course, we want to extend this type of test, and at the moment we are at 20 million cycles. We want to reach at least 25 million cycles to have a real fatigue test, comparing the features of this stent with, obviously, comparing with the other stents. So in conclusion, we didn't observe any damage of the fabric or of the stent struts after flaring. We found an excellent resistance to pull out and to the shear out forces. And now the fatigue tests are ongoing, but we have to wait for 25 million cycles to better compare the resistance of the different bridging stents used for this indication for fenestrated and branch graft. I would like to point out that this type of stent is not approved in all countries, so please observe the instruction for use before you use these stents in fenestrated or branch grafts. So this is the first step, the fatigue test. And now I would like to ask Professor Gargiulo to show one case so that we can really see the performance of this stent in vivo. And please ask questions, so many you want. It will be a big pleasure to answer your questions and to discuss this topic in depth. Mauro?
Thank you, Giovanni. Thanks
Please.
a lot. I think that your introduction is absolutely perfect because you introduced the modality how the answer of the VBX to the fatigue test, to the porosity test, and I think that in this new endograft, it is very important to define correctly the effect of the fatigue test, of the porosity test, and the risk of a fracture of the stent before to use this stent graft in clinical practice. And according with your presentation, your first presentation, I want to share with you and all the colleagues that are involved in this webinar the case that one of the cases that we treated with this type of stent graft in patients that we treated with fever endograft. And this is a patient of 70 years old. He's a male smoker with hypertension. You can see that the renal function was quite normal, and the patients had a previous endovascular treatment of abdominal aortic aneurysm with Medtronic Endurant endograft. And in these patients, in the follow-up, we defined the presence of the aneurysm above the endograft, and the diameter was about 62 millimeter, and the aneurysm involved the origin of the celiac trunk. You can see here the CT, and you can see exactly the location of the Endurant that was deployed in the juxtarenal position. This is the CT of these patients with the normal descending thoracic aorta, but at the level of the you can see here the passage between the thorax and the abdomen. You can see the aneurysm and the location of the visceral vessels and the Endurant endograft in the abdominal aorta with good patency regarding the two limbs without any type 1B endoleak. In these patients, according with the morphology of the aneurysm and the previous endograft, we decided to make a customization regarding endograft, and we decided to use fenestrated endograft with a branch for celiac trunk. But we defined this morphology of the endograft according with the location of the aneurysm and according with the diameter of the aorta at the level of visceral vessels. This was the hypothesis for the revascularization of celiac trunk with a branch, and in according with the clock view and the diameter of the celiac trunk, in our idea, we decided to use VBX 8 to 79, and I want to stress this aspect because if you use branch, you can use sometimes long VBX, and the VBX have the possibility to give us the 8 centimeter stent graft. It is, I think it's a very important point to decrease the numbers of the stent graft in case of the distance between the branch and the visceral vessel is more than 5 centimeters. Regarding the superior mesenteric artery, we decide about the revascularization through a fenestration. In these patients, in this fenestration, we decide to use the VBX 7 to 29. And regarding the right renal artery, we decided VBX 6 to 29, and for the left, according with the diameter of the artery, according with the distance between the stent graft and the visceral vessel, we decide about the VBX 6 to 39. We reported that in these patients, we treat the patients with endograft, then there is an endurant endograft. Then in these patients, frequently, we need to add a bifurcated endograft below the fenestrated endograft, and frequently in patients with the previous endograft, we need to use the inverted limb morphology of the bifurcated aortic endograft. This is the morphology of the endograft at the level of the abdominal aorta, at the level of the common iliac vessel, at the level and distally to the endograft, the iliac and the femoral axis. Generally, we define before the treatment the bone landmarks to define exactly according with the column, the location of the visceral vessels, and we defined exactly the location of T at the level of T12 for the superior mesenteric artery and for the renal arteries at the level of the L1. And with the angio view simulation, we generally define preoperatively the correct angulation that we need to use during the procedure to have the possibility to see correctly the origin of the different visceral vessels, celiac trunk, SMA, and the right and left renal artery. Then we decided to treat these patients in 2 steps. Why? Because we can discuss if you want, but generally when we treat the patients like thoracoabdominal, we prefer generally in the elective cases to use the 2 steps procedure. Then the first step was a step with the CSFA drainage, and we implanted the custom-made endograft, and we recanalized, we connected only the SMA, the left renal artery, the right renal artery, but not the celiac trunk. Then we did this endoleak between the step 1 and the step 2 to decrease the risk of spinal cord ischemia. Generally, we use the CO2 angiography in patients that need the endovascular treatment of pararenal, juxtarenal, or thoracoabdominal to define correctly the origin of the celiac trunk of the SMA. You know that the CO2 is a gas, then the gas floats in the anterior wall of the aorta, and then we can see very well the celiac trunk and the SMA to define correctly the location of this vessel, to define exactly where we need to deploy correctly the stent graft. In a patients with endograft, we generally prefer to balloon the limbs before the introduction of the stent graft, because in our experience we had a migration, a proximal migration of the iliac limb with an increase of type 1B endoleak at the end of the procedure in patients that needed the endovascular treatment of pararenal, juxtarenal, or thoracoabdominal aortic aneurysm in patients with EVAR in the previous EVAR. In these patients, then we introduced the custom-made aortic endograft. We deployed partially the custom-made endograft according with the angio and the location of the visceral vessels. Then, generally, the first step is to introduce the material inside of the SMA, and you can see that we use the flexor inside of the 7 French flexor inside of the SMA, and after the introduction of flexor, generally we use angio to define correctly the location of the introducer and the distal landing zone when we have to deploy the stent graft for the connection between the aortic endograft and the visceral vessel. For the right renal artery, we use a rim catheter, and you can see the same procedure on the right renal artery, and the same procedure for the left renal artery to define exactly the anatomy of this visceral vessel before to introduce the stent graft. After that, we deployed totally the endograft, and after the deployment of endograft, we started with the deployment of VBX in the different visceral vessels. We are endograft with fenestration, and then we need flaring in this stent graft. You can see the procedure regarding the right renal artery with this VBX 6 to 29. First, you can see the positioning of the stent graft inside of the fenestration, the deployment and the flaring of the stent, and on the right side you can see the final angio for the revascularization of the right renal artery without any problem in the distal landing zone, but even in the proximal landing zone at the level of the flaring that we did. And I want again to stress your previous introduction regarding the tests that you did regarding this stent graft when you need to flare the stent without risk of a fracture in the proximal segment. The same procedures we did at the left renal artery. We used the VBX 6 to 39, and again on the right side you can see the final angio with the distal landing zone without any dissection, any problem in the distal landing zone, but in the same time, so no problem regarding the proximal landing zone without any endoleak at the level of the fenestration. We did the same procedure even in superior mesenteric artery, where we used the VBX 7 to 29, and you can see the final angio. And again, here I think that it's important to stress in patients with fenestration and the use of the VBX that is very flexible, decreased in our experience the use of adjunctive procedure like the use of self-expandable bar stent that sometimes we needed in the past to use as to decrease the angulation of the SMA in the distal segment of the stent graft inside of SMA. Then this is another very important point that I think it's important to stress in case of fenestration when we have to make a revascularization of the SMA. I reported that when we need to treat aortic disease with fenestrated endograft in patients with EVAR, sometimes we need to use inverted limb, and these are the image of the deployment of the inverted limb, and you can see here the revascularization of the left and the right common iliac artery. At the end of the first step, we had this morphology with, without endoleak between the two endografts, the thorac-abdominal and the abdominal endograft, and without any problem regarding the revascularization of visceral vessels and regarding the distal landing zone. You can see correctly in this image the distal landing zone of the VBX in the renal vessels. After this first step, we did a second step 5 days after the first one, and we did a revascularization of celiac trunk. In this case, I remember you that we used the branch, then you know it is possible with a steerable sheet to cannulate the branch from the below, from the groin, but generally we prefer to go from above, from the brachial axis, and you can see that from the brachial axis we introduced the flexor inside the celiac branch, and we introduced the guide wire inside of the celiac trunk. You can see the anterior, posterior, and the lateral view of celiac trunk to define exactly the location of the bifurcation of celiac trunk and the location of distal landing zone. We deployed the stent graft. In this case, again, is 8 to 79 VBX, and I want to stress that we can use with this endograft 79, and this is a very important factor in when we have the possibility to use the VBX in patients that need revascularization of visceral vessel through the branch endograft. And another very important point that I want to stress that this was the final angio at the end of the deployment of the VBX, and you can see the distal segment of this stent graft in the lateral view, and you can see that the distal stent graft is like elephant trunk inside of celiac trunk, because we used 8 millimeter, but the celiac trunk diameter distally before the bifurcation, above the bifurcation, is about 10, 11. Then we decided to flare even the distal segment, and you know that the VBX is a flexible stent. It's possible to make a post dilatation with the adaptability of the stent graft to the artery, and you can see on the right side the different morphology of the distal landing zone of the VBX. And this was the final result, the final angio with the revascularization of hepatic and splenic artery. This was the final, the CT after 1 years of follow-up. You can see in these patients that there was a exclusion of the aneurysm, patency of celiac trunk, SMA, and visceral vessels, renal arteries, and distally you have this type 2 endoleak that was presented in the preoperative evaluation of these patients. Only to stress the morphology of these VBX in the celiac trunk, you can see the adaptability in the branch and distally at the level of the distal landing zone of celiac trunk. You can see here the SMA with flaring inside of stent graft, aortic stent graft at the level of fenestration. And you can see here the two renals with a revascularization of the renal arteries without any problem in the distal landing zone, but even you can see the stent graft inside of the aortic endograft. Then this is the case that I want to share with you, is a fenestrated endograft. And to conclude this presentation, we think that according with our experience, but you recently published, Giovanni, a very important paper in the GVS regarding your experience, and we think that we can stress that this is a stent graft way that we can use for fever and beaver, because this is a stent with high radiological visibility, the possibility of the adaptability of the stent graft to different morphology with flexibility and conformability. And I think that it's important to stress that the Gore-Vian VBX is indicated for endovascular grafting of peripheral vessel. Then, according with these aspects, we think that we can use this endograft for fenestrated branch endograft. And it's correct, we have to wait the long-term results, but if you look to the mid-term result and post-operative and perioperative result, we think that in our daily practice, in our clinical practice, we can define that this endograft is an endograft that demonstrated safety and efficacy in this application in aortic disease. This is the case, Giovanni, that I want to share with you and to hope to discuss with all the colleagues that are
yes, and we have a lot of questions, and I'm glad about this. And I have the impression that the people who are connected are very experienced, and it will be a big pleasure to speak, to answer the question, to discuss some points. One point is from Sander, who asked about how many days or weeks between the two steps. You know, you showed a staged approach, and what would you suggest?
But you
how
know
long
that
should we wait between the two steps?
the steps, you know, Giovanni, we normally use this clinical approach according with the studies that other colleagues did in Leipzig regarding the role of collaterals after the exclusion of intercostal. And according to the literature and this experience, you know that we need minimum of 4 days between the two steps. Then generally we start from the day number 5 to day number 10 or 15 according to the clinical situation of the patients. If the patients after the first step had a normal post-operative period without any complication, any problem, generally after 5 days we start with the second step. If we need to wait according with the pulmonary aspects, cardiological aspects, renal aspects, generally we wait for 6, 7, sometimes 10 days, but generally we don't leave the patients outside our hospital. We generally prefer to do the two steps during the same period inside of the hospital. This is our approach. It's not totally scientifically supported, but with this approach we had a decreased percentage of spinal cord ischemia in our clinical practice between the first period and this second period of treatment of thoracoabdominal aortic aneurysms. I don't know, it's even you, your approach.
Yes, I agree completely, and I think that the approach should be tailored to the situation, tailored to the patient, to the condition of the patient. Bridging stent for the celiac trunk can also be done by local anesthesia. It's also a question of reimbursement. You know, if you increase the costs in this way or not, it depends on the situation also of the hospital and so on. So if the patient has a huge aneurysm and the risk of rupture is high, I wouldn't wait too long. But if this risk is not very high, I would probably wait longer. It depends on the patient, I would say.
Yeah, but I totally agree with you. We need to tailor the approach according with the situation. In this case, we decided 5 days because after the first step, the patients had a very good post-operative period, and then we decided to start immediately, and then we concluded the treatment in 5 days. Yes.
I mean, if the extension is another one, for example, type 2 thoracoabdominal aneurysm, in this case, we use a thoracic endograft first because we cover a lot of intercostal arteries. and then we wait, I would say, at least 1 month,
Yeah.
so that we have a good collateralization or increase of collateralization. So in this case, we wait at least 1 month, and then we implant the branch graft or the fenestrated graft in this patient. So in such cases, we would wait longer.
Yes, but I think I totally agree with you. We need to define according with the extension of the aneurysm and according with the quality of thoracoabdominal. Sometimes in aneurysmatic or post-dissection, probably you need a different approach. Then depends of different variables, and I totally agree with you. Sometimes we did 3 or 4 steps to not only 2 steps, and depends of the risk of spinal cord ischemia, even according with the patency of vertebral arteries and hypogastric artery. This is another very important point to define. Yes.
Yes. One point was how we calculate the shortening of the stent. We know the BBX is a balloon expandable stent, so it's obvious that we'll have a shortening depending on the diameter we want to reach. And you mentioned that we can adapt the diameter of the stents to the anatomy of the patient. Very often we see osteostenosis and then a post-stenotic dilatation of the stent graft. So a balloon expandable stent has the advantage that we can tailor also the size and the length of the stent, of the bridging stent, to the anatomy. So, but how should we calculate the shortening? I think that the Goa company help us. If you have a look at the package, you know exactly what will be the length of the stent graft depending on the sizing, on the pressure of the balloon. I mean, if you increase the pressure up to 12, 14, the shortening can be very exactly calculated. And this aspect has an important impact for avoiding type 1C endoleak, especially in patients with thoracoabdominal aneurysm treated with beaver. So how can we avoid a type 1C endoleak in such patients? And I had the question, very interesting question from John. So how can we calculate the sealing zone length in this patient? How long should it be? And also, should we perform any oversizing of the VBX inside the target vessel? So I suppose everybody has another strategy. Perhaps you can tell us your strategy, Mauro, and I can speak about our experience, because this has also an impact on learning curve. Learning curve has been addressed also by Andrew, and we should collect all these aspects together in sense of that.
I think that this is a very important point regarding the length of sealing zone, because during the learning curve, we had a case of dislodgement of the stent graft of VBX because we decided to stay only 1.5 centimeters inside of the renal vessel. And we learned, even according with your center, Giovanni, that we need to stay more than 2 centimeters inside of each vessel. This is very important, I think, when we are speaking about the beaver. Different probably is for the fever, because it depends of the distance between the endograft and the ostium of the vessel. If you have to treat this patient with beaver, absolutely you have to stay more than 2 centimeters if it's possible, according with the bifurcation of the visceral vessel. If you have to work with fever and you are very close to the ostium, I think in our experience we didn't have any problem regarding the stability of the stent graft if we were inside of the visceral vessel 1.5 centimeter or 2 centimeters. Then I think that depends absolutely of the morphology of the aortic endograft. Regarding the oversizing of the stent graft, this is our philosophy always, is with this type of balloon expandable stent graft, but even for the others, generally we don't use oversizing in the distal landing zone. We prefer to work with the ratio 1:1 with the diameter of visceral vessels. And generally with the VBX, we prefer don't use oversizing during the ballooning, the inflation of the stent graft and the deployment of stent grafts, because we learned from your center, Giovanni, that if you increase the oversizing, you can have in the follow-up the risk of stenosis in the distal landing zone. And then I think that we need to have a learning curve, but at the same time, we need to have experience from other colleagues and to have the possibility to learn from other experience, other colleagues, to define how it is better to deploy the stent graft and how it is better to guarantee the proximal distal landing zone. This is our approach generally, Giovanni.
Absolutely, I agree completely. And well, we have a sort of trade-off, you know, between the risk of edge stenosis or dissection also of the target vessel from one side, and the risk of type 1C endoleak. So our strategy is don't oversize, like you, don't oversize the stent, and if possible, to go deep inside in the target vessel. Obviously, without compromising side branches, which can be very important in the SMA and also in the renal artery. But this is important. This, in my opinion, is also especially important in thoracoabdominal patients. So we learned by Dr. Fazzini that the main body of the graft after the implantation for thoracoabdominal aneurysm has so many morphological changes due to migration, due to shortening of the main body, due also to scoliosis of the graft inside a large aneurysm. So we have a lot of changes. So it's important in my eyes to go deep inside in the target vessel, and the VBX is extremely flexible. So these changes of the main body can be compensated by this type of bridging stents, in my eyes. Well, we have a lot of questions, but we have only 2 minutes to go. So should we use VBX more in fever, more in beaver cases, or in both? Mauro, do you have remarks?
Yes, generally we use the VBX in the fever as a case that I presented, but even in beaver, because you know the flexibility of the stent graft can adapt better this stent graft to the visceral vessels, in particular the level of renal vessels. Because if you have a morphology of the renal vessel with upward of renal artery, you need sometimes to guarantee adaptability at the level of the ostium, but even in the renal arteries without any kinking distally. Then we generally use VBX today in visceral vessels treated with fenestrated and with branch endograft. We don't have any difference between the two group of stent grafts. You, Giovanni, you prefer to use
well,
VBX?
I mean, using VBX in the thoracoabdominal aneurysm, using especially 79 millimeter bridging stent, you can save money. Because in the past, we used 2 or 3,
Sure.
sometimes also with relining for only one branch. And so also from the financial point of view, I think, especially in BIVA cases, VBX can be very, very useful. Yes. Actually, the time is out, but I have one important question by Thomas. Do you ever seen fractures or kinking of VBX, Mauro?
My answer is very quick because we followed all the patients that we treated because they are in our registry, and we didn't have any case of a fracture or the major fracture or any kinking that needed re-intervention at level of VBX in patients with BIVAR and fever. Then my answer was no, we didn't have this complication in the follow-up of our patients.
Also, in my experience, we didn't have. And the last question was the comparison with other bridging stents.
Yeah, you know,
we are performing now a comparative study comparing VBX with the other strategies. And I hope we'll have the results of this evaluation soon. But what is your experience, Mauro?
But Giovanni, you reported your experience in the bench test in the introduction. Today we use, regarding balloon expandable, 2 different balloon expandable stent graft. And if I need flexibility and conformability, I prefer to use the VBX because, you know, in some anatomies like SMA in patient with fenestration that I presented you, or in case of branch endograft with upward renal artery, you need to guarantee in the landing zone the absence of kinking. And we know that kinking is in favor of occlusion of the visual vessel in the follow-up of these patients. Then generally, if we need flexibility, we prefer to use this stent graft and not the competitors.
Okay.
Yeah.
Thank you so much, Mauro. Perhaps the time is out. I have a sign from the regie, but perhaps you would like to say something to other colleagues.
Yes, it was a great pleasure to share with you, Giovanni, this afternoon, and with all the colleagues that are in contact with us with this webinar today. And I want to thank Gore to give us this opportunity to speak about the VBX, about this new stent graft that we are using in the fenestrated branch endograft. We think that according with the structure of this stent graft, according with your bench test regarding the fatigue test, the porosity test, according to the experience that we have in the literature. You recently published your paper about your experience, Giovanni. We published last year our preliminary experience. We think that we can use this stent graft today because we can guarantee the efficacy and the safety of the procedure with this stent graft. We have different good aspects of this stent graft, but I think that according with the literature, according with the experience that you presented in your introduction, we can think that in the future this will be one of the main stent graft that we can use in the treatment of complex aortic disease with complex technique like BIVAR and fever.
Okay. Thank
Then
you, Mauro.
thank you very much.
Good
It was a great
afternoon.
pleasure. Good
Was
afternoon to you.
also from my side. Thank you. Bye-bye to
Bye-bye.
everybody.
Bye.
Bye-bye.
Bye-bye. Bye, Giovanni.